multi-system inflammatory syndrome of child.
So
that was classification of congenital and acquired heart. So, but how these children with heart problems is present? So, symptomatology, adult cardiology is completely different. The spectrum of disease is completely different. What we see in adult is usually ventricular dysfunction, wall-related issues, or coronary artery-related issues, myocardial ischemia. But spectrum of disease in pediatric heart disease is completely different. So their presentation is different, and there are general or systemic findings will be different. So if we inquire on inquiry or on history, if we get these symptoms, poor weight gain, repeated respiratory tract infection, breathing difficulty, cyanosis, which is central cyanosis, dyspnea or breathing difficulty, and any child who is become sick, otherwise unexplainable or sudden sickness is there, or there is a history of persistent fever more than 15 days. Or on examination, if we get unexplained tachycardia, tachypnea, pulse difference, upper and lower limb pulse difference, visible cyanosis, deep blue child, or on pulse oximetry saturation is less than 94%, or there are on general examination there are obvious external congenital anomalies, and on auscultation if you get abnormal second heart sound and murmur. So if you get any of these, I have simplified this. Such babies need further cardiac evaluation. There are high chances they are having underlying heart disease. It could be congenital or acquired heart disease. And diagnosis is confirmed by, as all of you know, it is confirmed by 2D echocardiography. So we'll see briefly about how they are managed. If heart disease is diagnosed, how they are managed. So there are two options: medical management and surgical management. Not all of them require surgical management. Most of can be managed medically. In PDA, in premature babies, there are certain medications we can close PDA by ibuprofen or indomethacin. And certain congenital heart defects, which are ductus arteriosus dependent, the circulation or hemodynamic stability is dependent on the patency of ductus arteriosus. If you diagnose them on time, you need to start them on one drug, which is a wonder drug, prostaglandin E1, or it is also from alloprostatine. There are certain anti-failure medication which are used for heart failure, which is secondary to congenital heart defect or acquired heart disease. Beta blockers and ions supplement, they are given in newly diagnosed congenital cyanotic heart defects till they surgically corrected. Antiplatelet medication after device closure or stenting. Antiarrhythmic medication if there is a rhythm issue. Infective endocarditis prophylaxis. Infective endocarditis is high likely child is having congenital heart defect. And certain medical treatment options are also available for rheumatic heart disease, Kawasaki disease. Surgical treatment. As large group of heart disease in children is congenital heart defect, we'll see surgical treatment options. Do all congenital heart defect require surgery? Answer is clear no. Small physiological shunts like patent foraminal, patent ductus arteriosus, which is less than 3 days, they are physiological shunts. They flow spontaneously, and even they don't require even follow-ups. But small shunt lesions like small atrial septal defect, small ventricular septal defect, or small patent ductus arteriosus, they have a high chances of spontaneous closure. So they are abnormal. They are not physiological. They are abnormal. They require follow, but there are high chances of spontaneous closure. Moderate to large shunts. Yes, definitely there are these babies with moderate to large shunts. They are symptomatic like large VSD, large PDA, atrioventricular septal defect, and there is hemodynamic compromise. That's why they are symptomatic. So if they are having symptoms, you have to start them on anti-failure medications till they surgically corrected. Cyanotic congenital heart defects. Now earlier it was thought if it is a cyanotic congenital heart defect, surgery is very much complicated and child can die. No, it's not. Cyanotic congenital heart disease, they require surgical closure definitely. Urgent or early. Urgent means immediately. Early means within couple of days or 1 week or 1 month maximum. And what is the prognosis of cyanotic congenital heart defect if they are defect?
They usually require single stage surgery and excellent prognosis. They live a normal life. I am following many of such children post-operatively. They are doing well. The defect is surgically corrected on time, diagnosed on time, and surgically corrected on time. They are living normal life. Only for complex congenital cyanotic heart defects, they require multiple stage surgery and prognosis is really guarded. But with newer surgical techniques and many centers are coming up in India, they reach till with this multiple stage surgery, they reach up to adults. With very complex anatomy, certain cases are inoperable. We have to clearly tell the parents, and such patient can be managed medically alone. So that was brief discussion about pediatric cardiology, spectrum of disease, symptomatology, diagnosis, and treatment. So we'll see what is the current status of pediatric cardiac care in developing world first. So this information I got from an article which was published in 2019 by Dr. Anita Saxena from AIMS Delhi. So she has mentioned first the burden of heart disease globally in pediatric patients. It is 1.35 million, means 13,50,000 babies are born with congenital heart defect globally each year. If you see the ratio of cardiac care which is being provided for such high burden in developing world, ratio of cardiac center, if you see in developed world, in North America, one pediatric cardiac surgery center is there for a population of 1,20,000. If you come down to Asia, it is 1 in 16 million, means one center for 1.6 crore population. If you go to Africa, only one center for 3.3 crore population. And even worse is, these centers are clustered mainly in metropolitan area. So that is again worse situation. So 90% of babies who are born with congenital heart disease, they live in a region where medical care is inadequate, but it is actually not available. So this privilege of early diagnosis and timely intervention, and it is restricted only for developed countries or the baby is born in metropolitan cities. Now that was about some figures about congenital heart defects. Now see acquired heart disease, rheumatic fever. Every year in high prevalence regions in developing countries, 282,000 new diagnosed rheumatic fever cases are reported. These are only reported cases. We know equal number of more than that they are not reported actually. And 233,000 patients, pediatric patients die of these diseases. It is very sad. Is the rheumatic fever incidence, its prevalence really decrease? No, it is actually we are not diagnosing them. Now I mentioned these figures from the same article. If you compare how many patients are clinically diagnosed as a rheumatic fever, how many of them are actually subclinical and diagnosed echocardiographically, 10 times higher. Now coming to the status in India of pediatric cardiology care, this is very recent information, last year article by Dr. Siva Subramanian Ramakrishnan. It was published in Annals of Pediatric Cardiology, September 2021. So how many numbers of pediatric cardiac centers in India? It was only 14 in 2005 as per status report. Now it is increased. In last year, number increased to 90 pediatric cardiac surgery centers. This inquiry among the Pediatric Cardiac Society of India. So this is actual figure. Now most of these pediatric cardiac surgery centers, they are concentrated in major cities and mostly they are privately run. Now I am practicing Sangamner, Loni, Srirampur, Kopargaon. I have to refer this patient for if they require pediatric cardiac surgery to Mumbai or Pune. There are 8 to 9 centers in Mumbai who are performing pediatric cardiac surgery and 5 to 6 good centers in Pune as well. So they are located mainly in metropolitan cities. Distribution is not uniform. Now I have given this example. Kerala has 8 neonatal cardiac surgery centers. Kerala is a small state. 4.5 lakh annual childbirths is there. They have 8 neonatal cardiac surgery centers. While most populated states in India, Uttar Pradesh, Bihar, see their annual childbirth, and it was census 2012, 48 and 27 lakhs respectively. Not a single neonatal cardiac surgery. So it is very sad state of affairs. cardiologist ratio. Now we are having many adult cardiologists. Pediatric cardiologist ratio, if you see, US had total number of approximately 3,000 pediatric cardiologists as per 2019 report. Ratio was, considering the US population, it is 1:30,000 population. One pediatric cardiologist is there for 30,000 population. In India, total 300 pediatric cardiologists. These are figures of intervention pediatric cardiologists for a population of 140 crore nearly. Ratio is one pediatric cardiologist for population of 45 lakh people. This ratio is again was for pediatric cardiac surgeons. Accurate numbers are not available because pediatric cardiac surgeons, they are actually qualified adult cardiac surgeon, MCH, their last degree is MCH, CVTS, and thereafter, as they have interest in performing these surgeries in pediatric population, some of them, very few of them, practice exclusively as a pediatric cardiac surgeons. Their actual number, that's why it's not available. And fellows are also trained. Like I have been trained as a fellow in pediatric cardiology, non-invasive pediatric cardiology after my MD. So their number annual training is just 35 out of approximately, as I remember, approximately 2,000 MD pediatrics or DNB pediatrics yearly. They are coming up, and out of only 35 of them are trained as fellows. Now that was some figures from India. Now I am practicing a rural setup. So what are the ground reality? What are the difficulties in management of such patient with limited resources? First and most important is less awareness among the practitioner about the magnitude of problem. What is the magnitude of the problem and what is the pediatric cardiology care is available, just we have seen. So this is less awareness. So we can increase awareness by through the CMEs, free camps for the pediatric screening, cardiac screening can be made, and this information can be further updated through the conferences as well. Second problem is availability of pediatric cardiologists. I have earlier mentioned the figures. So actually, pediatric cardiologists, they are not available for the rural population. So this screening to the echocardiography is done by trained echocardiographists, radiologists, certain radiologists, they do good pediatric 2D echocardiography as well. And most of these patients are actually handled by adult cardiologists. Third problem is, if they such patients which turn out to be heart disease, commonly it is connected to heart defect, counseling them, push them for a surgery or push them for certain intervention is really a big challenge. There is a lack of awareness. There is a fear of going to the metropolitan cities. They never gone before. Affordability is a big issue. And certain social and familial influences. Like neighbor are saying, no, my child was diagnosed with some hole, but it was automatically hit. So that is not the issue. We are pushing them for a surgery, it's a big problem. So most of them, in my experience, 50% of them they don't go for a surgery on time. Fourth important factor hurdle is the cost. But nowadays I am taking active participation in managing their finances. It becomes my responsibility. I am diagnosing congenital heart defect and they require intervention or surgery. So this cost, how it is managed through certain schemes, Rashtriya Bal Suraksha Karyakram, MJPGY, or all these hospitals, they are privately run. Still they have their own trust system to arrange the finances. And CM fund, they give 1 to 2 lakh per case. Chief Minister fund, it is also available. For that, what they require, just few documents. मी भारताचा नागरिक आहे आणि मी गरीब आहे. To prove that, Aadhaar card, ration card, income certificate, birth certificate. Because child born, they don't have Aadhaar card, so that's why birth certificate is required. Again, fifth challenge is a post-operative follow-up. Is it over that cardiac surgery is confirmed and child is completely normal? They require follow-ups in many of the cases, at least for a year, depending on the defect and the surgery performed. So post-operative follow-up is also very poor because of their poor understanding, and people people think that now surgery is done, they have spent so much money, your child is now, no, it is not so. And I have purposely mentioned the 6 point, need for pediatric ICU. I am working in this region. So pediatric ICU is available, which is 8-bedded only in Pravara hospital. In surrounding areas, approximately 50 kilometer radius, there is no pediatric ICU. I am not demanding for pediatric cardiac ICU. Even such babies can be managed in pediatric ICU, pre and post operative care. So this is need of an hour. Some newly passed MD pediatrics, they can think, form a group, and 3 or 4 people can set up a 5 to 10 bedded pediatric ICU. So certain preventive measures and screening. Yes, treatment for a bacterial sore throat can prevent rheumatic fever. You have to diagnose this pediatrician duty to diagnose them as a bacterial sore throat and give antibiotic for adequate duration. If you are starting azithromycin, give it for 5 days at least. If you are starting amoxicillin, give it for 10 days. Mass immunization against rubella. As we know, maternal rubella causes congenital rubella syndrome, and one of the component of congenital rubella syndrome is large PD. So, immunize this.
2 minutes.
Yeah. If we immunize this patient for rubella, this large PD can be prevented. Antenatal detection of CSD by 20 weeks, we come to know whether heart is normal or abnormal. We can decide about termination of pregnancy. It is a complex CSD. And screening of newborns with pulse oximetry to diagnose critical congenital heart defects. It is very simple technique. Just take the saturation of newborn baby at least by 24 hours of life. We can diagnose as a cyanotic congenital heart defect. And cardiac screening of school children is possible for the parents as well. So I am sharing some interesting cases that I have managed. 3-month male child with clinical features of large shunt, means he was having breathing difficulty, fast breathing. Sent to me for performing 2D echocardiography. His heart was normal. Actually, it was pushed down in the epigastric region. But I found why it is so. So I checked the air entry. It was less on the left side, left lung, and did this X-ray. It was showing large mass in the left pneumothorax. It was there is actually shift of the mediastinum to the right side. See the trachea. I did a CT scan. Fortunately, it was available there. So that turned out to be premature death. So it was not a cardiac case. It was a mass in the thorax. He got operated in hospital. He is doing fine. 9-day-old neonatal baby with prolonged O2 requirement. Most of the NICU baby there is a prolonged O2 requirement is there. We are treating them for a sepsis. We are treating them for a respiratory distress syndrome, congenital pneumonia. But this patient, this is echocardiography picture. Actually, this turned out to be a case of supracardiac PAPVC. So this is the pulmonary venous complex, which is behind the area, and this is the large area which was shunting right to left. So management is completely different. I had sent this patient for PAPVC repair, and he's doing fine. 2.5 months old with respiratory distress 2 days ago. Classical shape of the heart, A1 side appearance. He was a case of transposition pericarditis with VSD. His father was an army person. He got operated in military hospital. He is doing fine. This is case of Epstein anomaly, box-shaped heart. This was a case of similar features, fast breathing and breathing difficulty. It turned out to be a case of congenital pylorothorax. So there was no refilling after we removed that fluid. This was a case of, see the mass in the LV. Actually, it was a case of rhabdomyoma. Rhabdomyoma is the component of tuberous sclerosis. This is a very unusual case. Actually, we don't see such cases.
Excuse me, sir.
Yeah, only one. So this is a echocardiographic picture. There is something moving in the upper chambers. These are the atria. Interatrial septum is not. It is forming like a common atrium. This was the case of infected endocarditis large VSD. He was having prolonged fever more than 15 days. He received antibiotics for many days. But I diagnosed as a case of infected endocarditis, and cause for this underlying cause was atrial septal defect. We treated him for 6 weeks, given antibiotics, and he got prepared for the ASD. He's doing fine. And certain few cases I also manage for patient with very less ejection fraction, critical aortic stenosis, that dilated cardiomyopathy in 1 month baby, certain antenatal congenital heart blocks, twin TAVC is very rare. Both the twins had TAVC. One was having supracardiac, one was having infracardiac TAVC. I sent them to Kokilavan Ambani Hospital in Mumbai. Unfortunately, one child died, one is survived. I am also managing Kawasaki disease. I have seen first case of neonatal infective endocarditis. Take home message: heart disease in children are commonly congenital in origin. CSG is more than 90% they are repairable. Only if they diagnose and corrected on time and they live a normal life. High index of suspicion is the key. Services at peripheries, they are coming. It's a good sign. And pediatric cardiology care, I will summarize with this statement. In India, it is evolving. Actually, it has grown from its infancy to its just childhood. So, lot more work is to be done. Thank you very much.
Thank you, sir.
Next speaker is Dr. Abhijit Patel, sir. I request him to please come on the dais. He is interventional cardiologist from Ahmednagar. Working in Swasth Hospital, his own hospital in Ahmednagar. He has done MD Medicine, Gold Medal, DM, DNB Cardiology from Mumbai University. Working as an interventional cardiologist. His areas of interest is angioplastics and public awareness. So I welcome, sir. Please start the session.
Time constraint, we will be ringing a bell 2 minutes prior to the allotted time. So I request the speakers to please manage accordingly. Thank you.
केबल नहीं मिलेगा देंगे डायरेक्ट लैपटॉप
कॉपी करून घ्या. 2 मिनिटं.
Good morning, everybody. With initial technical glitches, I think we are now over. I thank Dr. Kute sir, Shirampur IMA, and the organizing committee for giving me an opportunity to interact with you all. Everybody is interested in what is new. Nobody is interested in what is old. And as we age and age, initially things used to work for 10 years, 20 years. Now things keep on changing every couple of years. Nobody is interested in Katrina Kaif and Salman Khan. Everybody is interested in Vicky Kaushal and Katrina Kaif. So things become old very fast. So I'm going to talk about very few things. This may be a glimpse that how the overall scenario is changing, and we have to adapt to drugs which we have not heard also of those drugs say 5 years ago. This is one of the drugs, Arni. It's a valsartan and succobutril combination. Succobutril is a Japanese drug, and valsartan is a well-known drug for we are given for at least more than 10-12 years for heart failure. So how they decided to combine these drugs? Because they thought that valsartan is useful but to a limited extent. Succobutril per se technically would act if you look at the pharmacology of that, but it was not acting on its own, so it had to be combined with some other drug. So the scientists came with the idea that let's combine succobutril with some other drug. So they tried combining succobutril with drugs like ramipril, but it was very hazardous. It caused a massive adverse effect in the form of angioneurotic edema. So that combination was scrapped. Then valsartan was a very standard drug for heart failure. So they decided that let's combine valsartan and succobutril. At least the animal trials were very successful, and then phase 3 clinical trials, and then the drug came into practice, and it was a miracle. There are very few drugs in medicine who have a mortality benefit, and this is one of the drugs which has come in last 4 or 5 years, which has a mortality benefit. Like if you give in patients with heart failure with reduced ejection fraction less than 35%, and we see these patients right, left, and center. So all these patients, if they are put on this drug, the first agent, this was approved as a new class of drugs called angiotensin receptor neprilysin inhibitor, ARNI. ARNI is easier to remember rather than the full form. The medication was just FDA approved to treat patients with chronic heart failure with reduced ejection fraction. And now heart failure is such a common phenomenon that we see heart failure because of increased incidence of diabetes, increased incidence of hypertension, increased incidence of ischemic heart disease. So heart failure is the thing which we are seeing the most in our clinical practice, and that's the reason why the guided directed medical therapy (GDMT) reduces mortality and morbidity, and many eligible patients with heart failure with reduced ejection fraction are not receiving recommended medication, including ARNI. So ARNI is a must for all patients who have heart failure with reduced ejection fraction. If we are not giving them this drug, then we are not doing justice to them. So this drug is a new drug which is now available. And fortunately, initially, as all drugs, this drug is very costly at present. And the cost plays a role till the drug is in patent. But fortunately, this December and the patent is ending. So in January, market will be flooded with 50 companies selling this drug at a very cheap cost. And that will be very advantageous to our patients because more and more patients can take this. As of today, the per day therapy of a good dose of this drug costs almost 75 to 100 rupees. So once the cost comes down, I think this drug will see more and more. This drug is in a cohort of patients with heart failure with reduced ejection fraction. It may provide favorable effects of not only improvement in symptoms, but also have a mortality benefit, as I have already said. We all know that all these heart failure patients, they were offered expensive devices like ICD, implantable cardioverter defibrillator, because they suddenly have episode of ventricular fibrillation and they die. And that is the reason why anybody who has an ejection fraction less than 30% actually was advised the ICD. And addition to that, if they had some ECG abnormality, they were advised a combo device. Combo device is ICD plus pacemaker, which will resynchronize the LV and RV contractility. So these are expensive devices. A combo device costs almost 5 to 6 lakh rupees. So once it was observed that once the patients are ARNI, the overall chances of them requiring these devices also goes down. So these are the drugs that have changed the way people practice, and we have to be aware of these drugs, and more usage of the drug, I think we'll see in time to come. Another drug like that is SGLT2 inhibitor. This also drug came as a drug for diabetes, and now it is a cardio-diabetic drug. That it is now there are trials which have proven that patients who are non-diabetic also, those who have a heart failure, they should be given this SGLT2 inhibitor. So basically, what does this drug do? What these agents do? Glucose, which is reabsorbed in the body, in the kidneys, is not reabsorbed because of inhibition of this SGLT2 pump, and that's how more and more glucose is excreted, and that's how drugs are, the blood sugar comes under control. But as we know, with sugar, lot of urine also is passed, so it has a diuretic effect, and there are effects beyond diuresis. That this drug also is known to cause mortality benefit, especially drugs like empagliflozin and dapagliflozin have caused mortality benefit in patients with heart failure. So this drug also is more and more used in patients. Only thing is, contraindications for this drug would be anybody who has a renal failure, glomerular filtration rate less than 45, or diabetic ketoacidosis. In these drugs, in this situation, these drugs are useless. Not only useless, they are harmful because they can worsen the dehydration associated with diabetic ketoacidosis and can cause problems. Since SGLT2 inhibitors can cause mild degree of dehydration, they should be used in conjunction with medication that predisposes to acute renal injury. Patients with predisposition of bacterial urinary tract infection or genital urinary tract infection also are prone for complication with this drug, because as we have discussed, these drugs cause more and more glucose to be excreted in the urine. So urine is rich in glucose. That's why it becomes more prone for bacterial infection, for fungal infection, especially in female population. So these drugs, once they are started, one has to be aware of the urinary tract infection complaint by the patient. All these years, we have seen that everybody is bothered about cholesterol and everybody is bothered about LDL cholesterol. We want to decrease LDL cholesterol somehow, and LDL cholesterol, once it is decreased, it is proven beyond doubt that it decreases the chances of you getting any atherosclerotic, either heart disease, cerebrovascular disease, peripheral vascular disease, everything. So the most standard drug for treating LDL cholesterol was statin, either atorvastatin or rosuvastatin. These are the commonly used drugs. But the commonest side effect of these drugs is myalgia. So many patients keep on complaining of myalgia with these drugs, and unfortunately, good options for statin were not available. But recently, this is drug which is called bempedoic acid. It's a basically adenosine triphosphate citrate lyase inhibitor used once in a day, reducing LDL cholesterol level in statin refractory patients. So this drug will be used in two situations. One, patients which cannot tolerate statin, or even after giving good dose of statin, their LDL cholesterol is not coming down. These drugs are very useful, approved by FDA in 2020. High levels of LDL are major risk factors for cardiovascular disease. So beyond life, hypercholesterolemia can significantly reduce the quality of life and increase the risk of mortality in cardiovascular disease. About 1 in 4, which almost 25% patients are insufficiently managed with maximally tolerated statin therapy because of the side effects. And the combination of these drugs, bempedoic acid and drug like ezetimibe, will be very useful in patients who are statin refractory. So these drugs will be used more and more in patients who are statin refractory to get down the LDL cholesterol, because previously only one therapy was available, that is monoclonal antibody, which is called as evolocumab, and it was very costly. My couple of patients are taking evolocumab. It cost almost 70 to 80,000 rupees per month. So that is the reason why these drugs would be very useful, and once they come out of patent, the cost also will come down. Couple of investigation I would like to highlight which have changed the way we practice. These are the investigations which are to be done in the ICU only. They are not to be sent to a pathology lab and then you get it. So we are doing this investigation in our ICU point of care. There is a small machine which is available. Procalcitonin, it is the way we diagnose acute myocardial infarction quickly. It is also important to diagnose sepsis very quickly. So alarming number of 18 million of new sepsis cases are reported in India. 28.3 patients contact sepsis during ICU stay, and 34% is the mortality rate. So the procalcitonin is detectable in 2 to 4 hours, peaks within 6 to 24 hours. So PCT production is not impaired by neutropenia or immunosuppressive states like elderly patients who have renal failure, those who are in sepsis can have a normal WBC count. But in them also the procalcitonin will be still high. It is levels parallel to the severity of inflammation. High procalcitonin, severe sepsis. And it has a prognostic indication also. If you demonstrate that after giving antibiotic therapy for 72 hours, if the procalcitonin level is dropping down, then probably you are on the correct line to treat the sepsis. So procalcitonin early diagnosis and prompt antimicrobial therapy is crucial in the treatment of sepsis for saving lives. And I think it is the difference between bacterial and viral respiratory tract infection. So PCT, procalcitonin will be raised only in bacterial infections. Determination of antibiotic treatment, length of respiratory infections, diagnosis, risk stratification, and monitoring of sepsis and septic shock. This is the way, so many times we are in dilemma that we feel that the patient is in sepsis and we don't have a clue. In that case, this investigation has come to a big rescue and has changed the way we practice. If the procalcitonin is high to start with, then you can hit the patient with a good antibiotic and definitely it has a better outcome. Now, in fact, point of care machines are available which will give they amplify the antigen within the blood of the patient and can give you the antibiotic sensitivity within 2 hours. So these are also, there is a machine called as biofire technology. So they amplify the gene and give you the drug sensitivity within 2 hours, and that will change the way people practice. In metros, these investigations are available, but they are very costly. One biofire investigation costs almost 20,000 rupees. The PCT is relatively cheaper. It costs almost around 1,000 rupees, but has a sea change in the treatment of the patient. Another point of care investigation we are doing regularly in our ICU is NT-proBNP. NT-proBNP, imagine a patient who is a smoker, who known COPD, comes with breathlessness, clinically has no bronchi, no threats, patient is breathless, ECG is okay, echo is yet to happen. We don't know whether we are treating COPD with exacerbation or we are treating left ventricular failure, because the patient has a good chance of having underlying ischemic heart disease as well. So NT-proBNP is useful in such patients. Two main type of NT-proBNPs are standard now. We do NT-proBNP in all patients. This is the classical subset of patients which I already described: difficulty in breathing, coughing, fatigue, swelling of abdomen. If your NT-proBNP or NT-proBNP are high than normal, probably means you have heart failure, and usually higher the level, more serious is the heart failure. NT-proBNP results are normal, it probably means your symptoms are not being caused by heart failure, and your healthcare provider may order more tests to help to make the diagnosis. So same way, NT-proBNP helps us to diagnose heart failure, not only diagnose it, but if you treat, the NT-proBNP will come down. If you, at the time of discharge, if you do NT-proBNP and say, if normal is less than 125, if it is 2000, patient comes back to you after 1 month and you do his NT-proBNP, and if it is again 4000, then probably again he is going into failure. It gives you a clue that you have to step up either some of his medication, either maybe diuretic or drugs like Arni or drugs like beta blocker, something like that. You have to do something for the patient because his NT-proBNP is rising. There are a couple of markers. There is a marker called as ST2 marker, suppression of tumorigenicity 2 marker. So many patients we see of terminal heart failure, their ejection fraction is very bad, and we don't know what to do about these patients. So a couple of patients we have done this marker, and if the marker is more than 30, ST2 marker is more than 30, it is the fate of the patient is sealed. This patient, if doesn't undergo heart transplant, will die within next 6 months. That is the data. So ST2 marker also helps in Western countries. It helps the patient to jump the transplant list. Anybody who has a ST2 marker which is high is pushed up the transplant list so that he gets an early heart transplant. Though in India it's a distant dream, because heart transplant surgeries are relatively less and happening only in India. I think it is happening only in Pune and Mumbai. Other than other cities, I don't think heart transplants are regularly happening. But it's a new horizon that we have to have a look at it. We do see patients who are undergone heart transplantation, and like kidney transplantation, it will also be more and more common. So these are new investigations, new drugs, and though we practice our standard medical treatment in so many patients, these drugs help us to change the way we think about all these patients. I thank you all for giving me a patient listening. Thank you.
Our next speaker is Dr. Amol Madhushali, sir. I request him to please come on the dais. He is minimally invasive thoracic surgeon from Thane. He is medical director of Dr. Madhushali Hospital in Central. He is consultant at Pedi Hospital, Leelavati Hospital, Mumbai. His special interest is VATS, video assisted robotic thoracoscopic surgery, robotic thoracic surgery. Please start the session.
A very good morning. At the outset, I would like to thank Dr. Ravindra Kute sir and the organizing team of MASTACON 2022 for giving me this opportunity to share my experience and my work. Greetings from my home ground in Thane. So, as we all know, lung disease burden is huge in India. There's a 50% increase in the incidence of lung cancer over the last decade. And there's a huge pool of operable patients if caught at the right time. 1 in 5 cancer patients die of lung cancer. So lung cancer definitely has a high mortality and therefore we need to catch it early. There's a tremendous burden of non-cancer pathology as well. Long-term effects and sequelae of COVID-19 are still seen. TB, as we all know, is no less than an epidemic and it's all over the place. India has the highest TB burden in the world. 4.5 lakhs people die annually of TB in India. So when we think about thoracic surgery, most of us would see these common interventions and the removal of a part or whole of the lung, decortication, treatment of recurrent pneumothorax, and removal of various tumors in the chest. Most of these cases are done through such large incisions, which is nothing but a thoracotomy. And when the patient walks into your clinic for a follow-up, they do have a fair amount of discomfort. Literature has described even a post-thoracotomy pain syndrome in up to 60% of patients for as long as 4 to 5 years. So pain and discomfort is definitely troublesome. As surgeons, we started thinking, can we do better? Can we go minimally invasive? And that is how thoracoscopy and then VATS, that is video assisted thoracoscopic surgery, started. So what is VATS all about? It's nothing but laparoscopy in the chest. That's as simple as I can put it. Of course, the instrumentation is slightly different. We need some sophisticated, dedicated VATS instruments and also some stapling devices, some consumables. And thereby practically every surgery in the chest can be made minimally invasive. Like you see here, there are small holes which we make in the chest to do these surgeries. What can be treated? Almost everything in the chest. So TB and other infections, complications of TB such as cavities, bronchiectasis, destroyed lung, cancers, lung and esophagus, undiagnosed complex pleural effusion, empyema, recurrent pneumothorax, mediastinal tumors, conditions of the thymus, chest wall tumors, and the list is endless. To add to this list is our dear pandemic COVID, and we saw this a lot in during COVID, especially in ventilated patients. They developed pneumothorax. Obviously a tube was inserted, but the lung didn't expand. Patients developed bronchopleural fistulas and then hydropneumothorax and empymas. And we have operated 16 of these patients, and out of them, 13 were done by VATS, and all of them did well with good expanded lungs. I'm going to show you one case later in my talk. So current status in lung cancer in India is that, we don't have low dose CT screening the way Western population or even China has. Therefore, there is early detection and better results. Just to give you an example, 15,000 major lung dissections were performed for lung cancer at the Shanghai Pulmonary Hospital in 2021. Their 22 numbers are still to come out. But so unfortunately, we lag far behind. And that's because of no screening programs, lack of awareness, and neglect of early symptoms. Just to give you a reminder, stage 1, 2, and 3A lung cancer are amenable for surgery. So we should all try and detect these patients as early stages as possible. Next, coming to something which is lesser known, need for surgery in TB. There is a recent upsurge in drug-resistant TB, and the situation is similar to the pre-AKT era when there were no AKT drugs available. Today, although drugs are available and newer drugs are coming up, the bacteria go on becoming resistant to these drugs. Drugs don't penetrate affected parts of the lung. And a lot of TB bacilli are situated in tuberculomas or inside abscesses and cavities where antibiotics can't penetrate. In long-standing TB, there is a phenomenon called end arteritis obliterans. So there is no vehicle to carry these drugs to those affected part of the lung. And therefore, surgery eliminates this part of the lung and the bacterial load. Thereby, the further AKT can kill the remnant bacteria and thus render the patient disease-free. Indications for thoracic surgery in TB are diagnosis of complicated cases. So it starts right from diagnosis, elimination of contagious persisting cavities despite appropriate AKT, treatment of destroyed lungs, tuberculomas, and pleural empyema. WHO has clear-cut indications on when to operate drug-resistant TB patients. So they say that if there is no respite despite 4 to 6 months of drug-sensitive supervised antituberculous treatment, localized disease, chronic sputum positivity, morbid complications of parenchymal disease, and relapsed patients should be taken up earlier for surgery. They even go one step ahead and they have spoken about timing for surgery. So they say that the resection surgery should be timed such that it gives best chance of cure. So it makes more sense to perform elective procedure at an early stage when the disease is localized in one lung or in one lobe, rather than then later on performing it when the disease spreads to a second lobe or the other lung. These are Indian guidelines which also speak very similar to the WHO guidelines. For taking up these patients for surgery, the minimum investigation is a CT thorax. So on X-ray, when any of us suspect anything which cannot be treated medically, please get a CT thorax done, and it gives us much more information, and thereby you can decide if this patient needs a surgical intervention or not. These other investigations are of course done once the patient is considered for a thoracic surgery. And as surgeons, we put the patient on a rigorous pulmonary rehabilitation program and make the patient stop smoking for at least 15 days before taking him up for surgery. That gives us definitely better results. Most of these surgeries require general anesthesia with a one lung ventilation. So only one of the lungs is kept ventilated during the procedure, and the other lung is one which we operate. But nowadays, some of these surgeries can be done under local anesthesia with sedation or regional anesthesia, and the indications for this lesser anesthesia are increasing day by day. Let's come to a few common case scenarios that we all see in our practice. So this first case is a 44-year-old gentleman, a smoker, came with right-sided chest pain since a month and a 3 kg weight loss. On auscultation, the right-sided lower zone air entry was decreased. So I think most of us would agree that one of the most common clinical diagnosis here would be a pleural effusion, and that is what we saw on the X-ray. These are 2 X-rays done 2 weeks apart. So in the second X-ray, you can see that the fluid is already getting a little more organized. Now here, what would you do? First thing is obviously chest ultrasound and tapping, diagnostic and therapeutic. Sometimes even after tapping thrice, you don't get an answer. What am I dealing with? What is the pathology? In some cases where the effusion is large, you would get an intercostal drainage put. But for undiagnosed effusions, finally you have to have a CT or a PET and a pleural biopsy, which is done by VATS. Because unless you do a biopsy, you don't know what pathology you are dealing with, and the patient is never going to get better. Some of these pleural effusions get complex. So as I showed in the X-ray, they get organized, and then no tapping or no ICD is going to be able to drain this fluid. So thereby again a CT scan and subject these patients for VATS. So this is a typical CT scan of something called as a loculated pleural effusion. You can see that on the inner side. So on the lung side, you can already see a line between the fluid and the lung, which is nothing but thickened pleura. Couple of short videos. So that's what we do in an undiagnosed effusion. Suck out all the fluid first. Take it up for investigations if not done earlier. Here there were lung adhesions also. So, and I could see an unhealthy lung parenchyma. So we took a lung biopsy as well. This is pleural biopsy and placement of chest tube. So all this can be done under local plus sedation, and this takes not more than 35 to 40 minutes. So it's a relatively short procedure, but gives a great yield and a confirmed diagnosis. This is when the same effusion stays for slightly longer, and post tapping, this patient unfortunately developed a hydropneumothorax. Now here you can see these fibrinous adhesions between the lung and the parietal pleura, which are first taken down. Then the entire lung surface has to be freed up. Only then the lung is going to re-expand. So the entire lung surface is freed up. All the fibrinous material, debris, everything is taken out, and we take pleural biopsies if the case is still undiagnosed. And you can see a good, nice expanded lung after this. Now this is an interesting case. This was a 56-year-old gentleman who came with respiratory failure bang in the second wave of COVID, and he was obviously COVID positive, required invasive ventilation, developed pneumothorax while he was on the ventilator. A tube was inserted, and later on he was weaned off ventilator, but he became oxygen dependent. The lungs still stayed collapsed. He had an air leak, and he couldn't be weaned off oxygen. So initially we thought of connecting negative suction to the chest tube so that maybe the lung expands and the leak stops. But that also didn't work, and finally he was considered for surgery. So this is what was done. This is the initial X-ray. This is after connecting negative suction. The same thing on CT scan, first CT and the second CT after negative suction. So the emphysema went away, but the lung still stayed collapsed and the pleura became even thicker. So when we went in, this was the picture. It was already a formed empyema. So the first thing is taking out all the empyema debris, pus, everything has to be taken out. The entire chest has to be cleaned. And this is, I tell the anesthetist to blow up the lung and fill in some water. So this is what we do to find a puncture. So I could see that there is an obvious air leak. Now, first thing is that the entire lung has to be completely mobilized. Earlier, you couldn't even see the lung. So there's a thick layer of visceral pleura on the lung surface. The lung has to be completely mobilized from the mediastinal side. Only then it is going to expand and touch the chest wall. So that's the pericardium, and that's how we mobilize the lung. So this is on the diaphragmatic side, then going posterior, and this is posterior. This is somewhere near the spine, and that's how the with sharp and blood dissection, the entire lung is mobilized. So that's the lung mobilization completed. Next is removal of the visceral pleura. So it is like peeling an orange. But here, the orange peel comes off quite easily. You rarely ever find that the peel is stuck to the orange. And here, even if the orange tears, it's okay. But here, there's a lung underneath. So you have to be very careful that the lung doesn't get punctured while doing this. So you have to find the right plane and take off the entire visceral pleura from the lung surface. So that's the visceral pleura out. And here, since the so next is, this is the leak. Now what to do with the leak? This was at such a site where that part of the lung couldn't be resected or stapled, and here, since these are COVID patients, we don't want them to lose lung parenchyma. So there was no option but to suture the leak. So it was sutured in 2 layers with PDS, and luckily the leak stopped. Then since the parietal was not very thick, we just did a mechanical pleurodesis and not a pleurectomy, and a good washout and placement of a chest tube. And you can see that the lung now at least looks like a lung, and it is expanding. Not as good as a non-COVID lung, but it's still expanding. This is the immediate post-op X-ray. This is at the time of discharge. I had to discharge him with the tube because there was still a small air leak at the end. And this is on the day of ICD removal, and this is 2 months post-surgery. So this is now like almost a normal case. This case was also published. This is the thick pleura, and now this case could be done by VATS. Most of them can be done by VATS, but we get patients with late empyema where VATS is just not possible, and you have to go in open. So this is an open decortication. Now here see the peel has to be literally dissected with scissors. It just can't come off, but we still are able to do it, and that's the lung at the end. But some patients do get unlucky, and the lung is so bad that it just cannot be salvaged. And sometimes lobectomies or pneumonectomies have to be done just for patients who have had a chronic empyema. Therefore, I say, which is also supported by literature, that first treatment of choice for pleural empyema is a critical determinant of the success, because if not operated at the right time, patient can end up losing the lung. Third case is again a 23-year-old gentleman, young patient, and had a similar episode of chest pain even 3 months back. Now again decreased air entry, and this is a classical pneumothorax. So again you start thinking, what would you do? Most probably, of course, you would intervene in every pneumothorax unless it is a very small one. So either a pigtail or ICD. If there is air leak, most of these patients are going to require an intervention at some point of time, if not the first episode. If there is no air leak, then and the lung doesn't expand, again you have to subject the patient for VATS. So this is a typical chest CT scan of a pneumothorax with a collapsed lung. This is what we have to do in the procedure, and that's a short video. So this is just to show you. Yeah, so this is a CT scan. You can see a large bulla on the left side. And as soon as we go in, this is a large bulla. So this large bulla was intact, but what caused the pneumothorax was this. So that's a ruptured bulla, and the ruptured bulla always will go and get stuck to the parietal pleura. So we have to first release all the adhesions here. After releasing the adhesions, I'm just fast forwarding this video because due to shortage of time. So longer the pneumothorax, more the adhesions, and all these adhesions have to be released. Once the adhesions are released, what we do is stapling of these bullas. So I'll just show you how we staple these bullas. So this is the large one which is punctured and deflated, and then comes an endo stapler which helps us to resect these bullas. So here obviously there's a large one, but even if there are small bullae and we don't subject this patient for surgery, just take out the tube because the lung is expanded, he can definitely have a recurrence because a small bulla can definitely rupture in the second episode. And after this is done, so this is the X-ray, nicely expanded lung. So that's what we do for a pneumothorax. Lastly, coming to lung resections. Common indications are cancer, carcinoid, TB cavities, aspergillomas, and lung abscesses, etc.
Excuse me, sir.
Yeah. So this is a large left lower lobe lung cyst which had recurrent infections, and we can now do even a lobectomy by VATS. Even a pneumonectomy can be done by VATS. The entire lung can be removed by VATS. This is how the dissection is near the hilum. That is the fissure being stapled. Next, going on to blood vessels. So this is just anterior to the descending aorta. Then coming again back up to the hilum. Now here you can see this is the artery going to that lobe, and see the dense adhesions of the lymph nodes around the artery. In cancer, these planes are much more cleaner. So once we dissect, then a vascular endostapler comes in to divide these vessels. I won't go into much details, but basically we do artery first, then the vein, and similarly they are dissected and divided with vascular staplers. Finally, the bronchial division. So bronchus is again divided with the stapler, and then the specimen comes out. So these are the port sites and the specimen. Few other indications are mediastinal structures. Most common is thymus and some mediastinal tumors. mobilization of esophagus for esophagectomy, also esophageal perforations, chest trauma, wherein loculated hemothorax like empyema has to be drained by VATS, and diaphragmatic hernias, phrenic nerve injuries, etc. Most of these patients have a smooth post-op course where they require low flow oxygen just for a day. Most of them don't even require ICU. This is a patient walking on the next morning after a VATS lobectomy, which is almost impossible after a thoracotomy. Several benefits of VATS versus open. Most important is, since there is no rib cutting or rib spreading, the pain and discomfort is much less. Obviously, it is cosmetically better. Since there is magnification and more accuracy, there is lesser blood loss. That is what statistics have shown. And a shorter hospital to stay and early return to work is very important, especially in a developing country like ours. Latest in minimally invasive thoracic surgery is uniportal VATS. So what you saw till now was instruments going through different ports and the camera going through a third port. Now all of this can go through just one single incision. And of course, there is robotic thoracic surgery like in other specialties. This is how uniportal VATS is done, just one single incision, 3 centimeters, scope, instruments, everything goes through that. And now this is coming up in a big way. So to conclude, lung cancer can be completely cured. Early detection at an operable stage is the key. There is definitely a resurgence of surgery in tuberculosis due to high incidence of drug-resistant TB. Pulmonary resection combined with adequate anti-TB drugs enables high success rates in almost 92% of patients. So by high success rates, I mean sputum culture conversion. And effusions and pneumothoraxes can complicate quickly, so timely intervention is required. Earlier the intervention, more the benefit, and minimally invasive thoracic surgery definitely allows a wider range of patients to benefit from surgical intervention. Thank you.
Thank you, sir. Sir, please stay on stage. I invite Dr. Pathak sir and Holkar sir to please come on stage. Now the session is open for question answers. If anybody has questions regarding all the 3 topics, please.
Scan is ventilation perfusion scan. You have to do it in cases where the pulmonary function is
हे काय बोलतात
हॅलो, आवाज येत नाही. हॅलो
बोलू शकत